Hi, we're live. This is Dr. Robert Watkins IV and Dr. Robert Watkins III. The Bob and Rob Show, coming to you live from Marina Del Rey. Facebook Live, we're hot and we're hip and we're getting it rolling again. I'm really happy to have my dad on. You know, I do a lot of this social media stuff and our app that we developed, the Back Doctor app. We've had 50,000 people download it in 2 years, which has been awesome. We do a podcast channel, all this kind of stuff. The best part of my dad is anytime I tell him I'm going to start podcasting or doing this kind of stuff, my dad's always like, let me get in on it. You know, when can I do it? When are you going to let me do it too? And so I love your enthusiasm and your spirit and your energy. And so you're on. We made it.
That's right. That's the deal.
So our topic today we're going to talk about, I realized doing stem cells a couple weeks ago, and I really appreciate Shonak Patel coming on. It was great, our first time right here. And evaluating these new products, is not easy. And I got a Facebook today from a friend who asked about stem cell injections curing a guy who was paralyzed. So how, as doctors, do we evaluate new technologies, new instrumentation, new biologics, new medications, and therefore how can a patient or physical therapist or athletic trainer or doctor or nurse or any other healthcare provider and patient, how do you decide what should happen in your body? And that's so challenging because we have I got 25 years of experience with training, you got 40 or 50. And even for us, it's a process that we work out on a daily basis. So how do patients do it? How are they going to decide what goes in their body? It's almost impossible. And in some ways, the internet is great, so much information, but it's also overwhelming. I got patients coming in going, well, can't you put this in me? And showing me a picture of some random piece of metal and asking if I can put it in them. And so how do you make that, how do we do that process? So my dad's going to start with the history of spine surgery and take us through the steps as to what has happened. How did we get to where we are today? What were some of the fundamental things that happened? And then we'll talk about spines because we try not to waver off too much. We're still spine surgeons. That's what we do. And so we'll talk specifically about spines. And I think it's interesting. We'll try and make it digestible for everybody so that you guys really know what's going on. And we'll come up to the modern days to different products that are used, fusions, artificial disc, and how we make those decisions. And I appreciate everybody joining us tonight. I mean, it's not any fun if nobody's watching and paying attention and making comments. So I appreciate you guys coming and joining us. And if you have comments, we'll catch up at the end, tomorrow. I'll go through your comments and respond. And if you have any topics for what you want us to talk about in the future, let us know because we got a phone. All we got to do is hit play. We can talk forever. As our family knows, we don't shut up when it comes to talking about spine. So if you guys enjoy it, let us know what you want us to talk about. We'll cover any topic you want us. And we'll do a little research if we need to and find out about it for you, and we can talk about it. So with that, why don't we start? Dad, why don't you give us a little history of surgery and how we got to this point?
When I look back on the great surgeons that I've been exposed to, and a lot of experimentation, a lot of research, and a lot of really concerned surgeons from the very beginning that taught me the care and individual care of each individual patient is the critical factor. So every time we look at some type of product, you look at it as how can this help that patient, Mr. So-and-so, that I've been concerned about, that I want to do the best for, is a critical part of looking at these products. You don't look at it any other way.
So it's a fascinating balance, isn't it? Because we look at numbers and statistics and 1,000 people here, 1,000 people here, get statistical analysis. So it's all about numbers and big numbers, but then it really comes down to we have a one-on-one relationship with a patient. They trust us. Are we going to put this in them? And that's what it is.
Yeah, we're the clinicians. We're the surgeons. We're the ones that people come to that depend on, and we make decisions based on what's best for them. So there can be huge companies and devices and a lot of big-time stuff, but it comes down to the basics. And Rob said it mentioned about history. I don't read massive textbooks as much as I read some just popular books. And one was called The Butchering Art by Fitz Harris, and it really covered the 1850s and 60s when Lister and people at the Royal Infirmary in Edinburgh came up with a concept of washing their hands before surgery and cleaning the room and cleaning the patient. I think in reading this book as an example, if his father-in-law hadn't been in charge of the hospital, he may have never been able to do this. At least it's been a 10-year delay. And what he went through and the criticism from the existing establishment as to wash your hands, what are you talking about? Well, you put that in context of the idea of a germ that Pasteur was working on, in context of ether and chloroform that other facilities were working on. Surgery up until that time had a lot of really fast surgeons because the patients were screaming, and everybody got infected, and these pioneers set out to make this where, no, the patient's actually asleep, and we're going to clean the wound and clean the patient and keep the wound clean, and we're going to be able to get a better result for our individual patients. I love that book.
It's kind of fascinating when you realize, like, they weren't even washing their hands. They were opening people up, doing surgery, stuff like that. They didn't know they had to wash their hands. And you wonder what we're doing today that they're going to look back in 150 years and go, what? They were doing what?
I jump ahead. I gave a talk one time for one of the companies as a guest lecturer, and it was the future of surgery, and I had a vision of something like Star Trek, where the patient comes under this giant table like in Star Trek, and they've got all the diagnoses and all the treatments taken care of without opening the patient. That was part of my presentation.
And we're getting closer to that, aren't we?
We're getting closer.
This computer-guided navigation we do for our surgeries, we get a three-dimensional picture of the spine in the operating room, put in screws into the patient where we see the bone three-dimensionally, and these cameras show us where the screw's going to go. It's amazing. I mean, it makes putting the screws in so much safer and faster that what your vision is coming into play.
I had the first image-guided system in Los Angeles for surgery, and it was in the late 80s and early 90s, and the technology just wasn't there. I mean, we tried to use it. We could do a few specialized operations, but to apply it to everything, we couldn't do it. The technology wasn't there. These scopes and spines that Rob's undertaking now, I did that operation, and the technology between when I was doing it 10 years ago to now it's like going to the moon or not, because it was been a fantastic evolution of technology. And many times these great advances in medicine require 3 or 4 different research tracks where, like, same thing, the anesthesia, the antisepsis, and are all arriving at the same place at the same time to give the result. And that's frequently true in our business, where we're trying to get the best thing, but we couldn't do it 10 years ago because this track hadn't developed yet. And so that research has that way of working. And
some of the fascinating balances is these people who were designing new surgeries and opening people up 150 years ago, where they really had no business doing it. They had no instrumentation.
Well,
I mean,
I'll give you an example. And The King of Hearts is a book about Walton Lillihei. And this was a man that at the University of Minnesota in the 50s and 60s undertook his mission to save the lives of children who were going to die due to heart defects. And through developing heart-lung machine, implantable electrical stimulators, all kinds of different technologies, he was able to save the lives of children that were not going to be saved, who were going to die from these defects. At the same time, every day he went home, a child had died that day in his operating room under his hands, until they could work out these techniques. And in the book, someone asked his wife, how did he do it? How did he come home how did he get up every day with these children dying? And his wife said, I don't know, he just got up and went to work every day. So these are pioneering type things that some of us, would have not been able to do. I've never been able to take care of young kids. But I've got 5 kids and 8 grandkids. So.
Yeah, the emotional burden. It's fascinating the personality it takes to do surgery on somebody.
Yeah.
And to care enough to really help people. And at the same time, the emotional burden you carry about things don't always go well. And especially if you're a pioneer, you're doing new stuff, people are going to die and end up in pain and all sorts of stuff. And how do you keep waking up the next day and go to work and try and do better and try and get better? You do research, you prepare, you practice on inanimate objects first, and you work your way up there.
Yeah. I've been exposed to a lot of different experimental tracks. I came from a great medical community in Memphis and companies that did research and great facilities and surgeons, and here in Los Angeles at USC and other places we trained here in town. I've been associated with these great surgeons that took the steps forward And in England, excellent exposure to men doing things that other people were not doing. And it's just a sequence of events where you're exposed to these people and you work the hardest for them over these periods of time. Then you take those things you learned and you apply it in a different environment. So we're exposed a lot of times to new and different ideas, and we're required to evaluate those ideas.
So let's talk a little bit about the history of spine and specifically your history. And it really started, I mean, like 1969. I mean, you started in medicine. When did you start medical school?
66.
66. So we're talking about 50.
I was the
53 years ago. That's amazing.
My first
it's awesome.
Experiment
Yeah,
was,
he looks better than I do.
My first experiment was I dissected out in vena cavas out of cadavers for a man named Dr. Robert Miles, who had a clamp to prevent pulmonary embolus. And that was my first experiment. That was before I think I started medical school. And he asked me to do these. We measured where the veins came off, so he would knock off a vein with his clamp. Also, I was my first team physician role was in the late 60s with the police boxing team in Memphis for the Golden Gloves, where I was the team physician, a ringside physician. So that's a long evolution of.
So tell me, let's get down to spines.
All right, spine.
So tell me about spine surgery. When you first started in it, they were doing fusions for scoliosis,
Yes.
and they were doing instrumentation, or they started even without instrumentation?
Yeah, and the combination is an ironic combination of the places where I trained that different surgeons had different approaches, and we were faced with my main dilemma, I think, and two of the main things was straightening out spines and fusing spines to produce a good correction and make the spine straight. But also, if you have a painful, injured joint in the spine, fusing that joint so it wouldn't hurt or paralyze somebody. You got a broken neck, well, sometimes you have to fuse that neck in a good position and take the pressure off the spinal cord so the patient's not paralyzed.
Let me digress 1 second, just for the people who aren't doctors, whatnot in the audience. The discs move, the nerves come out. For every disc, you got joints in the back, facet joints, all that moves. Scoliosis is a crooked back, where if you're significantly bent over, that causes a lot of problems, your heart and lungs, pain, everything else. And so straightening, and you can die from the crooked spine. Therefore, straightening the spine can save someone's life, and still does. And so fusions, typically, these days, we put screws and rods in to really physically straighten the spine. And then a fusion means get the two bones to fuse across the mobile disc. Come one bone. So you get rid of the disc. L4 and L5 fuse together. They grow together. That's why it's called a fusion. They fuse together. Doesn't move anymore. Keeps them straight, and hopefully doesn't hurt anymore because you stop the painful segment and you protect the nerves that are coming out. So that's the fusion.
Yeah, the surgeon that trained me, Mr. O'Brien in England, was trained in Hong Kong, treating tuberculosis of the spine by taking out the infected spine and making a new spine, in essence, and fusing it in a good position. He trained me in England. I came back to Los Angeles, and my first case here was tuberculosis of the spine, where we took out the whole infected area, put in grafts, and fused it, and then in crooked spines. But then the same people that trained me had a different tract also of a painful, injured intervertebral disc and joint. I was the co-director of the Southern California Regional Spinal Cord Injury Center, so we dealt with fractures and dislocations and potential paralysis in people. So you had to fix that spine. So infected spines, fractured spines, you had to stop the motion and fix it in a good position and protect the nerves and joints around that. Then ultimately, especially with athletes and other people, there are times when the joint hurts, it's been injured, and you have to fix the injured joint. And one of the techniques for that is a spinal fusion. Cervical spine fusions where it's next to your spinal cord, the joint is moving abnormally, hurting and pinching the nerve. You go in, you take the joint out, you fuse that, hopefully one joint at a time, and that fixes that abnormal motion and activity. So my era in spine was one of when to do a spinal fusion, stop the motion in a joint, how to do it safely, what technology to use, what type of implants and technology to use. And that's even evolved into when can we do an artificial disc replacement and ones that we had done fusions before. It's all part of the same concept.
And let me just, and so doing surgery for somebody with a crooked back or an infection or somebody who's going to be paralyzed, that's kind of obvious. If you don't, they may die. So you're cut a lot of slack to do surgery on the person. And just what my dad talked about, evolving into operating on people for pain. And we can't measure pain. That's what we do all day long. 80% of the people we operate on is for pain, and you can't even measure it. And so it falls into this gray zone of when are you really helping somebody and to what degree. Our results of fusion, to kind of jump ahead, people's pain averages an 8 out of 10 before the fusion. It averages a 3 out of 10 after. So if you're at an 8 and you're in agony, we get you to 3, you help them. But a 3 out of 10 means most people still have pain. They average a 3 out of 10. And so operating on pain is this gray zone, and doing surgery on a human so that they can go play a sport. And an athlete, I mean, you lived through the evolution of that, where when that first started happening, Frank Jobe, Curlin Jobe Clinic, and when that first started happening, other doctors said they're committing crimes against humanity, operating on a person so they can play a sport. That's silly and wrong. And now it's a given. Somebody gets hurt and we expect to fix them up and get them back on the field.
O'Donohue in Oklahoma, and I think it was 1953, the University of Oklahoma team had the first time more than half the team, if I got the statistics right, had surgery so they could play intercollegiate football. So those are evolutionary ideas that you're going to improve somebody so they can do high performance things. I think the main thing for us is that we have tried to hone down the symptoms to quantify the morbidity. How sick is this person? How much problem are they having? Where exactly is the pain coming from? You have to do all this before you start operating on people. Is that coming from C5-6 only? And what's the smallest, easiest, most microscopic operation we can do to stop that pain? That's part of our thinking every time we look at a patient. All these diagnostic studies come down to what level, what nerve, what pathology, pinpoint the patient's chief complaint. I mean, I know we're talking about fixation, but you've got to know what the patient's chief complaint is. What is it that has brought them to your office? And you have to ask, and you have to get that information. Then you can plan your diagnostic studies and plan the least invasive operation to get rid of that chief complaint. So I've got to do that preamble.
Right.
So that,
and let's just mention that 80% of the people we treat, we don't operate on. We have the Back Doctor app, our whole non-operative rehab program, and great physical therapists all over the country that can teach people. But when it comes to surgery, and that example is, somebody's got a crooked back, and you're thinking as a surgeon, hey, I can put in screws and rods and straighten this out with this computer and this scope and all this great stuff. And then you kind of go, what's your problem? Well, it's one nerve. I just got one problem with one nerve. Well, how about we just sneak in there with a microscope and take the pressure off that nerve in 45 minutes,
we do that
and you go home the same day. Forget the screws.
Yeah. And so that's the surgeon's obligation, to do no harm, take care of their patient, and try to design the best operation with the least potential risk for your patient.
Tell us about, instrumentation. These pedicle screws, people come into our office and everybody goes, well, I don't want a fusion. They've heard stories about friends and family. They had a fusion, 2, 3, 4 fusions. They can't walk. They're the work of the devil, And so tell us about the evolution of fusion. I mean, look at this thing. It looks barbaric. You put in screws and rods and lock people in place. I can't tell you how much I pride myself on spending time with patients, explaining to them what's going on. I got a podcast. Listen to this podcast before the surgery so you know exactly what's going on. Then they come in after surgery, 2 weeks, we take an x-ray, I put it up, and they look at it and they see the screws in them and they go, that's in me? It's kind of
hard to conceive.
It's kind of hard to conceive that somebody's going to put metal screws into you. And it works 85% of the time. It really helps people. So these pedicle screws and specifically, the evolution of putting the screws into people and what a stir it caused nationally.
Yeah. I think the first thing, start with these crooked spines, and a man named Harrington and other people put a rod in with a hook at each, hooks above and below with a rod to help stabilize that. They do the fusion. Risser Group here in town, other people, they do the fusion, and then the spine would get solid in a good position, and they would use this rod that was just fixed at 2 points. Well, there were times it didn't fuse, and if you set out to fuse somebody's joint and you don't fuse it it generally hurts.
And that's biomechanically demanding. The spine is moving. We want
Yeah.
to stop the motion, get bone to grow across it. That's crazy. That's trying to overcome biology. We take it for granted these days. We can generally fuse people with a 95% success rate. Well, it's not a given. It's biomechanically demanding.
And so it evolved to the time where in my training we used the Harrington rod and could fuse the spine with that. And then I became exposed by the time that I became on the academic faculty. I was exposed to this idea of segmental fixation, which means fix every single level, not just a long rod connected at two places, but we took wires and wrapped it around the spine at every level, and that provided more fixation. 6 points rather than 2 points gave you a higher fusion rate. It was more likely to fuse.
When was that?
Eduardo Luque, and that was in the 70s and 1980 when I became on the faculty. I did one of the first big Luque instrumentation cases at Rancho Las Amigas Hospital here in town. But it was Dr. Luque from Mexico that taught this wire. He literally took a wire, passed it in the canal, and tied it down to the rod. And so that was the idea that you're going to get a higher fusion rate and a better correction if you fix it at every point, called segmental fixation. And then about another decade, about that time, Art Steffi came up with the idea of putting a screw. Other people have done this too. I don't want to slight anybody. He put these screws in, and then he would take a plate and bend the plate into lordosis. Lordosis, this is going to come up a number of times. You need a proper curve in your lower back, and like that.
You want your back
That's
curve
normal.
like this, so you stand up straight.
Yeah.
As the discs degenerate, they collapse down. That's why we get older, we all get more and more bent forward, part of it. So if you fuse somebody, you can't fuse them locked, bent forward. Everything's got to work too hard to get you back up. That's why fusions 20, 30 years ago really could cause more pain. So if you want to fuse somebody, you got to correct that lordosis.
The angle. This lower part of your back needs to be in lordosis like this. Now, some background on the Harry Farfan is a professor from Montreal, since deceased, who wrote the book Biomechanics of the Spine. He goes to the National History Museum, dissected out, looked at all these cadavers and different people and bones, and reported to me that a gorilla has no lordosis in his lower back. Therefore, he can't lift anything over his head heavier than a banana. And that's why he walks on his hands. And if you want to be upright and have the muscles pull at the right angles, you need a curve in your back. And so if you fix somebody's spine like this, they're normally in pain and have a disadvantage. So this idea of establishing lordosis. Well, what Steffi did was he took these plates and bent them into lordosis, and then he cut the spine with chisels and things and cut the spine, put screws in at every level, and then screwed the spine to this plate and got good results. He stopped the pain from the joints. He had them in lordosis in a good position. But as often happens in medical technology, one of the problems that evolved were that subsequent surgeons didn't get the point about cutting the spine and making it shape the plate. So they put the plate in that wasn't bent in proper lordosis. Well, that caused a lot of problems. I ended up, I told Robert, I ended up testifying before Congress for pedicle screws because I knew it was going to be the standard of care. And gave back some stock options because I didn't want to have that influence the testimony. But the knowing that this pedicle screw fixation was going to be the right way to fix these spines, it just had to be in the right position. We did another paper that showed that some people stand with excellent curve in their back. They sit with zero curve in their back. So getting the angle right, and it depended on where they were on the operating table. See, people, some of the early surgeons doing this didn't get that. They had to be on the table in a sway back position when they put in the screws and connected the screw heads, because when that person stood up, he was in that position forever. Before these spinal fusions, we just lay the bone on, and they'd lay the bone on. Albee, Higby, all these famous guys. Wiltsey would just lay the bone on, and as the patient walked for 6 weeks to 8 weeks, the spine would settle out in a good position. They wouldn't get as many of them to fuse, but they would settle out in a good position, a kind of median type between sitting and standing position. Well, with these segmental fixation cases, when that person stood up, he was in that position forever. So it took the surgeons and took everybody, the technology took an evolution to realize how critical that was.
Right. So we're talking 3 to 5 years of hundreds of patients to realize, oh man, we got to pay attention to this.
We
And
gotta
you
really
don't know
put
until
them
you
on
do
the
it
frame
sometimes.
where their back is in the right position.
What about Steffi and he had class action lawsuits against him and was going to lose his job.
Most of the innovative people, Charlie, the famous total hip surgeon in England, I mean, he was censored and all the medical societies thought he was an assassin, a barbarian. He had all kinds of problems.
So
Lily High ended up, in trouble and everything else. So everybody's a lot of pressure. If you're an innovator and you've got this idea, you know it's going to work in your patient because you're experienced. You've worked with this before. You know it's going to work, and you work out the technology. Well, if you're the first one out, I call it, then you've got to be prepared to weather the storm of convention, of a lot of insinuation concerning your motives and other things. It's not an easy position.
Yeah, and just wait till you have to go getting called in front of Congress. I mean, go to D.C.
I volunteered
testify.
because I knew this was correct. I knew this was going to be right.
And the story he alluded to too is the biggest company in spine right now. One of the guys grew up with my dad in Memphis, and so part of it, I'm just going to mention this because as a doctor, we got all these ideas. We're trying to help people, and our intellectual property drives the industry, and this is a billion-dollar industry. And so,
I explain that too, because when you you have to work with a company. Get something through the FDA takes a lot of money. No doctor has that money, so it's going to require a company and a corporation to get it approved for use, and that's a proper thing. Maybe it works out better that way. But the surgeon has an idea, and what does the surgeon know? He knows from what his patients have told him, what his x-rays show after surgery. So he knows these things from practical hands-on experience. Well, the engineers and technicians with the company, they know other things. I think engineers, I kid them sometimes that they know two basic things, materials and connectors. They know how to connect things together. Surgeons don't know that too well. And materials, they know the behavioral characteristics of titanium versus steel. They know this stuff. And one of our friends' father was a Caltech guy in materials. He knew more than anyone in the country. And so materials and connectors, well, they come up with something that's this big, and the surgeon says, well, the hole I put it in is this big. Well, let's go back to the lab and work on it some more. And the surgeon knows a better look at what happens in bodies, because he's following these x-rays every month of these new developments, and he's looking at and he's talking to the patients. Well, engineers don't get to do that. Engineers don't get to see that part of it. So the in vivo, the active living type model is what the surgeons know, the doctors know, because they see it firsthand, they talk to the patients. But the technicians and the engineers, well, they test it in a laboratory. Well, they know how many times you can bend this thing before it breaks, and that's important information, but it's not the same information. So it's a combination of these people coming together that produces improvements for the patients.
And everybody contributes something. I mean, we've developed so many new products, worked with different companies, and a good engineer is amazing. I mean, I've had things where I'm like, this is not going to work. We're at an impasse, and there's no way to get past it. And the engineer goes, well, how about he designs a prototype. I got this little widget here that distracts it, and you're kind of like, awesome. I couldn't have done that. And so having great engineers are worth their weight in gold, and then having the companies with the money and the resources to run the research, because when are we going to do it? We got Facebook Lives to do Wednesday nights. That's our only free time.
Yeah, and one of this, what Robert was alluding to, a friend of mine from my hometown started this company, and he said, Bob, you went to SMU, would like go down to Texas Scottish Rite Hospital and look at this intellectual property, which was a cross-link to connect these rods together. I said, sure. We'll go down and have dinner, went down, looked at it, and that was the first intellectual property that he bought and built this big company out of, rightly so. And but it takes the surgeon to know, that at times, that's what we need under these circumstances. So it's a combination of working together. To have if you're a surgeon working in practice, you've got, a secretary, 3 nurses, something like that. Well, if you're going to work to develop a product, you're going to have people that do that. So is the company going to employ them, or are you going to pay for them out of your pocket? You have to work these things out. I had some good friends that got criticized severely in an article published in one of the major newspapers in the country, who criticized the fact that they were paid to develop this product. In reality, it was a combination effort. They were honest, sincere, hard-working doctors that wanted something better for their patients. And, excuse me a minute. So they were able to work with these engineers and technicians to develop the product. And part of the thing, if you understand intellectual property, I just read the Three Kings book about intellectual property in the music industry. I thought it was fascinating. I loved it. And understanding your worth and understanding your value. And I think, and also for 5 years, I gave I gave a conference at the North American Spine Society for young doctors on intellectual property. And your thoughts and your ideas are valued. And we had a motto that said, quoting one of the more colorful people in the world, "Don't give it away for free, boys." And you deserve to be compensated for your ideas, like everybody is in our country. So trying to work out that collaboration so that you are properly compensated for your ideas in an ethical, honest manner with these other people that bring things bring expertise to the thing together is the right way to do things, and that's what we've been able to do.
Yeah, and a couple things I want to say about that. One is I want to give a shout out to company reps, because the companies we talk about, you know, they may get a bad name because whatever, you know, it's a company. It's like Coca-Cola and whatever. But the reality is they're worth their weight in gold too, because they come up with new ideas to us. They tell us about new products. And have you ever thought of, and because they're not a doctor, they're not locked into a certain frame of thinking. They think, well, how about this? How about that? And so they're huge. They're a huge benefit to us in the operating room, at our preoperative conferences, everywhere else. And so the new ideas are huge. And the biggest thing about all these relationships that go around is transparency, is just being upfront. Hey, I work with this company, we help develop it, and everybody knows, everybody's on the same page. So the instrumentation of the pedicle screws, locking into things into place, and the biologics are big. Let's talk about artificial disc replacements, because everybody, you know, the fusions, the work of the devil. We got to get rid of that. You want to preserve motion, and everybody comes in to me and says, "Why don't you just preserve motion? Do an artificial disc." And it's usually somebody who's got an arthritic back and their discs and facet joints and everything. They say, "Can you do this artificial disc?" And you were right there at the beginning of the artificial disc and the FDA studies on the first 2 artificial discs in America. And tell us about what we learned of that.
We were one of the original 14 centers in the country that did the FDA safety and efficacy study on lumbar artificial disc. And we quickly learned the do's and the don'ts, the good things and the bad things. And it's one thing to preserve motion, but if that motion's painful, well, then it doesn't do any good, does it? And also, if the thing you put in there is made out of metal and plastic and it breaks, well, that doesn't do any good either. You have to have, every orthopedic surgeon, anytime he does an operation, he knows his salvage operation. If this doesn't work and breaks, I got to have some way to go back and correct this problem. And every good surgeon knows that when he's doing the operation.
Some of the great stories we've heard about new products like an artificial disc, you know, all you hear at first is, "Oh, it's great. It's like they used to fuse hips, and now they do an artificial, you know, hip replacement everybody." And that's what I was going to be with the spines. And that was when I was coming out into practice 17, 18 years ago. It was going to be the new greatest thing ever. Obviously, it makes sense. And then you put some in, and you get people with bad leg pain right after the surgery that they wouldn't have had with the fusion. And they got this bad nerve pain. And then the first thing the rep, I hate to blame reps, but you hear these lines, true stories. The rep goes, "Well, we've never seen that before." That's one. We've never seen that before. Number 2 is, "Well, Dr. Such and Such, he doesn't have that problem."
Yeah.
And then number 3 is, "Oh yeah, we got the solution for that. You just got to do this."
Yeah.
And so it's just,
So it's a great exchange at times, but everybody has the same problems, and for any surgeon in these areas that we're discussing, number 1 is you got to do what's best for your patient. You've got to choose the least risky, least invasive, most likely to take care of that chief complaint. And so you've got to understand that chief complaint, and you've got to go through you've got to have a systematic system of working up these problems. and the history and physical and everything else, so you pinpoint the problem and you have the best solution for the problem.
So for the lumbar artificial disc, you know, the first one that came out was huge. Everybody's going to use it, all that kind of stuff. But it didn't seem, it seemed a little bit not solid enough. You know, like when you put a device in, you want to know it's going to go where you want it to go and stay there and not move. At least do no harm. Don't make somebody worse. So the first one is a little sloppy, and I never really a big fan of it. Then the second one was more stable and at least stayed where you put it and didn't move. And so we started doing more of those and had pretty good results. And here's one of the fascinating parts about it as a surgeon is where do you fall out and what's your emotional tolerance for taking care of people who still have pain after surgery is. I had lumbar artificial discs that did amazing. I've got a guy right now still bikes 100 miles a week, and a girl who's running marathons, and so you get. But then, you know, if 80% do great and 10% do so-so, and another 10% are worse or have more pain, because that's what happens with fusions too. If that happens with artificial discs, what do you do for the 10 to 20% who aren't doing so good?
You have to have a salvage
You got,
operation.
what's your salvage operation? And so the first time we go in, we move the blood vessels to the side, we take out the disc, we put in an artificial disc or a fusion. Great surgery, still potential complications, but we do a lot. My dad, that's what he was doing in England and brought back to Los Angeles. So we got a lot of experience, safe surgery. But now your blood vessels scar down to the front of your spine. Going back in the second time, you got to try and move those out of the way. People have died from that, and it's a big
Very
deal.
difficult.
So going in the back and putting in these screws and pedicle screws, you know, these pedicle screws in the back and lock it down. Well, that's what they all said was the answer. Oh, just go in the back, put in the screws in the back, lock them in the back. Well, we had a couple patients we've done that on who it didn't fuse. Why? Because the disc is still moving. The artificial disc is still moving, and so it didn't fuse. And so, you know, what's your emotional tolerance? How much do you not sleep at night for how long over this case? And then the next time somebody walks into your office, do you recommend it again? Can you handle the lack of sleep and them? Which, you know.
Robert was recommended by one of the major administrators in the sports team here in Los Angeles to read the book Fast Thinking, Slow Thinking by Kahneman. And it's a decision. These are the decision-making psychologists, world Nobel Prize winning decision-making psychologist, and so you make these decisions. You can't be overly influenced by the last bad result, so you have to have a system for making the proper decisions in your patient's best interest.
And the moral of the story, like with the lumbar artificial discs, is they work, and the data looks pretty good. It's at least as good as a fusion, if not better in some cases, so it still works. But a lot of people don't do them anymore in America, not because it's a difficult surgery, but because we have those handful of patients who are struggling with it afterwards.
Salvage operation.
And let me just mention real quick, cervical artificial discs we do a lot more of because you can go back in and change it if you need to, because you can move your throat to the side and change it to a fusion much easier and safer than the lumbar ones. And that's why the usage of cervical artificial disc is dramatically more than the lumbar. And we still do lumbar artificial discs occasionally if it's the perfect case, but it's an issue that you learn over a 10 to 15 year period of time.
Yeah, we know surgeons worldwide that have a great deal of expertise. One of the surgeons in Germany that's a friend of ours that we know that we refer patients to at times. I mean, he does 5 or 6, 7 levels of combination of screws and rods and artificial discs and everything, and gets a great result. And some of his patients spend a week in the ICU. And for us to have one of our post-op patients in the ICU, I mean, it's tough. It's difficult.
I'm gonna mention one thing about that artificial disc is one thing, a surgeon who does a lot of lumbar artificial disc, you know, 2, 3, 4 levels, beautiful correction, straightens them out, they look great. And we see the post-operative x-rays, they come back and see us for follow-up and everything, but then 2 to 3 years later, instead of just 3 or 4 artificial discs in the front, the patients are coming back to see us, they got the 4 discs in the front, but they also have screws in the back with a dynamic system in the back that preserves motion and cement injected into every vertebra to hold the screws stable. Well, as a surgeon, that tells me that's the salvage surgery to put the screws and provide extra stability, and he's doing the salvage surgery the first time, which kind of tells you
He's a great innovator and a great surgeon.
and a beautiful surgeon. But as a surgeon, we kind of go, whoa. And am I going to start injecting cement, which is pretty permanent, screws into the bone, artificial disc? And I have to say, you know, some surgeons really do a remarkable job, and people do well, and people love them for helping them. but it also can be pretty dramatic as to what it takes to be there.
Yeah, and it takes experience to know what you're best at and how best you can help this patient. And no, I'm not going to be able to help this patient, but I'm going to refer you to someone in the world who I think can help you. Yeah. So that's the experience of a surgeon. You have to know. You have to analyze. You know, my daughter's a surgeon and very complex area. She looks at some cases. No, this is not suitable for what we do with this technology, and that's something we do also daily. And we've got this non-operative rehab program. I can't tell you how many times we know we can get this patient better without surgery by doing this non-operative program. So that's part of the equation every time we see somebody.
I'm going to mention something else, so some other technologies for the people who are into spines. These dynamic systems in the back I mentioned, where you put the pedicle screws in, but instead of a solid rod, it has a hinge or flexibility to preserve some motion, which sounds great. I mean, I got patients still coming in going, hey, can't you do that? The problem is that assumes the motion is going to occur in the rod and in the hinge, but a lot of times it'll occur at the screw bone interface. The screws will windshield wiper and loosen. So you think, oh, it looks great, sounds great, but it doesn't mean the human body is going to act like you want it to. And the human body remodels. You know, the spine is a living organism. The bones are not static. The bones are turning over all the time. Every year, you got a whole new arm. That's all new bone. And so your body's remodeling, turning things over. Well, if you put in some metal device in the human body, then it can remodel and loosen. Now, if you fuse it, you stop the motion and bone grows across the space. Well, the body remodels the bone and is constantly healing it and reinforcing the fusion. Well, if you don't fuse it and you try and preserve motion, it sounds great. The problem is the body may just loosen it and kind of just spit the thing out for.
All these bone spurs that are pressing on a nerve, sometimes we fuse the spine, and if you stop the motion, bone spurs go away because they're there in response to abnormal motion. Well, if you preserve motion, sometimes they get bigger. And you've got to, just takes experience to deal with these types of things.
We'll mention two other things that have come up. We were talking about stem cells last week and injections in the spine. You know, we've been sticking needles in the discs and injecting substances into the disc for a long time, trying to heal and regenerate the disc without having to put in metal screws and fuse it. So what's some of the first products you remember about injecting a disc?
Well, the chemopapan, I can never say it right, chemonucleolysis, I was one of the first people doing that in this area. And
when was that?
1980, in the 80s.
Right.
And,
so you hear stem cells injecting the disc, let's do that. That's a new concept. Well,
this was a papaya
35 years ago.
that dissolved the center of the disc.
Yeah.
And we had another one where we put in there and it ate away the center of the disc, you know, through the skin. I had some dramatically good results for disc herniations by doing the chemonucleolysis, but it had its downsides too. I put it in one guy one time who was a famous actor. I put it in there, his blood pressure drops, and you know, is this going to work out? And turned out worked out fine. But
and one of the downsides, people can get burning pain.
Yeah,
right.
And sometimes it collapses the disc and pinches the nerve.
Right. You want it to do something to the disc, and you got an idea. Let's have it do this. Just don't do too much, because
it's like the bone morphogenic protein,
right.
BMP.
Right.
Infused is a product, and BMP. A lot of the researchers took a real beating over that because this was a substance, a genetically produced substance that would cause bone to heal. Well, if that lowers if we have a 20% non-union rate where it doesn't heal. And now we have a 0% non-union rate by using a different product. The doctors doing the research for that product got a lot of criticism when it first came out because sounds like a simple thing, but you didn't know the exact dose to use in each patient. Seems like medication, you know how much your dose of your medication is, you take and everything. Well, no, this is a new product. We didn't know if you had to keep it still, like with screws in a still environment, and use a lower dose, and you got great results. You put it in a moving environment with a big dose, no, you got too much reaction there. And that irritated nerves and caused problems. So it took time for this product to work out. Now, it still produces the largest fusion, fastest, and best fusion rate of any product we have other than taking some big piece of somebody's hip bone. Everybody's heard of taking part of your hip bone for a fusion. Well, yeah, if you take your cancellous bone or bone marrow, we have a technique now for a little hollow drill that takes bone marrow that we can pack into a prosthesis to put in somebody. And using a small dose of this product in certain environments gives you a great fusion rate. But when this product first came out, people didn't know that. So it takes an evolution of potential complications at times, and you just have to pay attention and follow the research. We call it the coffee pot at the spine meeting. I for years was out at the coffee pot talking to people outside the spine meeting. They're presenting the inside the spine meeting, they're presenting the scientific papers, but I normally had read most of those and knew those results. I was standing outside talking to people. Well, are you using this product and what results you're getting? And you have to talk to people you respect, and you know they're good researchers, and you get a lot of information, but that's not easily found in published material.
And so we'll kind of summarize the process of evaluating, are we going to use a new technology in one of our patients? One is you just hear the idea, and does it sound crazy? And that's just some common sense. Does this make sense? And sometimes you're wrong. Sometimes I think that's crazy, and then 2-3 years later you're like, okay, maybe it does make sense. And sometimes the technology evolves,
like I said,
to where it gets better, and then it does make sense.
Technologies come together and suddenly it works.
Right.
That's
yeah.
the way science is.
Yeah. This endoscope. I went to a lab this past weekend. It was great. Ray Gardaki taught it, and a bunch of people. And this endoscope was great, and it's merging with computer navigation and with other techniques. When it all comes together, I mean, it's gonna be which it is. It's a great advance. But so the first thing you do is just listen to the concept. Does it make sense? Number two is you look at any research, any papers out there. You got Dr. Tom Bangs-Ness at USC, who's a great professor of mine, who taught me how to read a paper and be critical of it. And I can't believe how many bad conclusions there are from research papers where they don't prove a statistical difference because they don't have enough power to prove a difference, and they conclude there's no difference. Well, it may be because you didn't have enough power. And they publish that in a paper, and it's an incorrect scientific conclusion. It happens all the time. So you got to know how to read a paper and critique it. Don't just accept the conclusion and read the abstract. It's crazy what gets published.
I'm on editorial boards now, so I review papers for publication and
don't just have your nurse do it. No, you got to read it.
I do it. And this book, the decision-making book, Kahneman, helped me even good reviewing papers, because there's so much in our world that's true, unrelated. Yeah, that's true, and that's true, but they're not connected.
Absolutely.
And
don't forget with research and new technology, there's a 30% placebo effect. So comparing an artificial disc to a fusion, it's a randomized controlled study. You draw a hat. Nobody knows what they're going to get, but the patient knows when they wake up what they got. You have to inform them, right? So the patient, imagine you're going to get a barbaric fusion, or you're going to get this new mobile prosthesis, and a patient wakes up from the surgery and is told they got the artificial disc. Wow, man, they feel good. They got the fusion. They're depressed. So 30%, of it is just this placebo effect. So that's one thing you got to consider. Research. Number two then is find out who's doing it. And we ask all the time, who's doing this, and what names are associated with it. And the company guys love throwing out a bunch of names, and this guy at Duke and UCSF and all these big places, so you got to talk to the person. And then ultimately, before you do it, you got to go see someone else do it. And you learn so much being in another operating room with a surgeon, seeing exactly what they do. For better or worse. Sometimes you learn new techniques, other times you go, man, whoa. And then the other component is do cadaver labs. And that's one of the great things about this relationship between doctors and companies, industry, is the industry and the companies put on the labs. They buy the cadavers and the instrumentation and the lights and the microscopes that we can actually practice and see if it makes sense. So you test it out, and then you get to a point where you're ready to do your first case. And a lot of times having the surgeon come and visit you in your operating room and do it with you. You've been a great person and a role model for taking the time and having people come to your operating room, going to someone else's operating room, and putting the time in.
No, I've had great friends and colleagues that came to Los Angeles, came to my operating room, and did the first several cases with me. And we've had an open relationship like that. I want to mention one other thing, because what I said about the surgeon's role is he knows how to put these things in. And that's one thing I learned overseas in England with the doctors there, and Rob did the last edition. We've had 3 editions of a book called Surgical Approaches to the Spine. How are you going to put it in there safely? If you going into the spine causes more pain and symptoms than the whole operation beginning, you've lost the whole battle. So knowing how to put things in properly and connect them properly, the proper approach to the spine, is a big part of the contribution that I think that Surgical Approach to the Spine, the 3 editions have done, and other things. But that's part of the surgeon's role. He's got to find out what causes the chief complaint. He's got to have a safe, effective way of correcting that. And knowing the right surgical approach and how to put in a new device is the surgeon's role.
And one of the wonderful things about the medical community, and even humans in general, one of the things I love about Facebook and podcasts is you can share information easily. Click of a button and people can take it or leave it, and everything else is the books. I mean, my dad's book, The Surgical Approaches to the Spine, anytime I go international and teaching or anything international, somebody always comes up to me and says, first of all, they look at me and they go, "I thought you were going to be older," because they thought I was going to be
the last edition, right?
But they always say, "I thought you were going to be older," because they got your book when there was no other book on how to get to the spine. And the attitude, what you've said, is other doctors, when you read the book, other doctors said, "Well, if you don't know how to get there, you shouldn't be doing it." Yeah. And so you wrote a book to say, "Well, let's help other people, figure out how to do this." And that's kind of, I love that idea of, we teach all the time. We got our conference coming up on June 1st for physical therapists and athletic trainers. And like I said, our app, the Back Doctor app, if you can help people just make some concise information and then they can use, this information should be freely available. And the medical community is so great about having other surgeons. One of my big goals with other surgeons is, we've been through a lot of pain of learning to come up with this technique for how to do this surgery. Yeah. So if we can make it digestible and give it to you to save you some pain, I mean, how great is that? And vice versa.
The direct lateral fusion is one thing that he's done a brilliant job of. It's not the technology of what you're putting in there necessarily, it's how you put it in. And by working out the exact angles on the fluoroscopy and the monitoring and the technique of putting that device in, to me is 85% of the entire thing, to safely put that in. And so sometimes that's as important as what you're putting in there.
Yeah, absolutely. It's a system. How are you going to have this system to do the surgery reproducible every time, so that when you get some X factors, bleeding or different anatomy, well, then you just handle those, but everything else is reproducible and systematic. And that's one of the great things about medicine, is sharing all the information. So I hope this has been helpful. We've enjoyed it. If you have any topics you'd like us to talk about, text them to us, Facebook them, and visit our website. It's watkinsspine.com. We have videos and explanations of every surgery and spine on there. The podcast, we got 30 podcasts on every surgery you do and everything else. The podcast is Robert Watkins. Feel free to email or direct message us if you have any questions. We'd be happy to help you in any way.
Yep, that's exactly right. Hopefully we can share the men that have shared things with us.
And women.
Yes, absolutely.
Jacqueline
Perry was one of the foundational people in my learning pattern. John O'Brien was worked with Dr. Perry, and Jeremy Fairbank, John Webb, guys that helped train us and made a major contribution to what we're now discussing and doing.
Yeah, so thank you very much.
Thank you.
You guys have a good night. Bye.